Good afternoon, everyone. We are here with our another Facebook live session. Myself, Dr. Kanchan Durkar. I am fertility specialist at Oasis Fertility, Vakad, Pune. Today, we have with us Dr. Nilesh Balkawade. He is a clinical head and fertility specialist at Oasis Fertility, Vakad and Kharadi Center. We welcome you, sir, for the today's Facebook live session.
Thank you, Dr. Kanchan.
Yes, sir. So today we are here with another interesting topic and common topic that we come across. And today's topic is pregnancy possible with zero sperm count? So today's topic is about basically azoospermia. Zero sperm count is basically we call it in medical terms as azoospermia. So first of all, I want to know from sirs that what are the reasons for zero sperm count?
Yeah. So, azoospermia or zero sperm count is a diagnosis which is established once we have a semen sample which is centrifuged, and even after centrifugation, we cannot see any sperms. Then we call it as azoospermia, that is, no sperms in the semen. If we get to see few sperms in the semen after centrifugation, we call it as cryptozoospermia. So, azoospermia should be confirmed on a separate occasion 1 month apart, and then only we can go ahead and investigate the man for the causes of azoospermia. So, if we see about the causes, basically we have the testis which produces sperms. So, the causes can be either pre-testicular, that is, those hormones which are acting on the testis can be a problem, which is called as hypogonadotrophic hypogonadism, and the cause is usually in the pituitary gland in the brain or in the hypothalamus. Then we have something called as testicular cause. So the problem can be in the testis. This usually the testis can be hypofunctional or malfunctional, and because of this there can be azoospermia. This usually gives rise to a non-obstructive azoospermia. Then we have post-testicular causes, that is, the testis has an outlet which is connected to the epididymis, and from the epididymis, the semen comes out through the vas deferens. Any obstruction in the outflow tract of the sperms is called is giving rise to post-testicular causes or obstructive azoospermia. So this causes study is important because the treatment of each one of these will differ.
Okay, sir. So another question related to these only, that which is the most common cause we come across among the patients coming, and how do we go ahead? How we investigate? How we come to know whether they are pre-testicular, testicular, or obstructive, that is post-testicular type?
So the important causes which we can see is any testicular cause is because of any damage trauma to the testis. One, any infections to the testis. This can be active infections in the adulthood, or maybe a past childhood infection such as mumps, where there has been orchitis, that is testicular inflammation, which has damaged the testis. Other problems can be tuberculosis of the testis and so on. Then the obstructive causes, mostly due to trauma, that is any injury to the uh, vas deferens due to any infections. That the second cause can be any infections, and these infections can be sexually transmitted infections or tuberculosis, which can cause obstruction in the epididymis or the vas deferens. Hypo causes, that is a hypothalamic hypogonadotrophic hypogonadism, can be due to any genetic problems such as Kalman syndrome or Klinefelter syndrome, and so on, where the pituitary and hypothalamic glands, they fail to function, and because of that the FSH and LH levels are low, that is the gonadotrophins are low, and since the gonadotrophins are low, there is no action of these gonadotrophins on the gonads to produce sperms, and therefore these patients will also have azoospermia. So these are the common causes of azoospermia. And the second question you ask is how to go about the diagnosis of azoospermia. The first and foremost, as we have already discussed, is the semen analysis done on two separate occasions. Now we need to analyze whether it is a pre-testicular, testicular, or post-testicular cause, for which we do the hormonal assay. The hormonal assay can be in the form of serum FSH levels, LH levels, prolactin, TSH, and testosterone levels. Now, out of these, the FSH and testosterone are very important parameters to guide you about the further line of management. If the FSH and LH levels are low and the testosterone is also low, this indicates that the problem is hypo, that is pre-testicular. So the hormones are itself low, so we need to supplement hormones in these patients. The second important scenario is where the FSH levels are high. Now, why these FSH levels are high? Because the testis is not functioning well, and therefore the brain thinks that it has to work more, and therefore the brain starts secreting FSH more, and therefore we have high FSH levels in testicular causes, that is non-obstructive azoospermia. We will have high FSH levels, and the testosterone is usually normal or slightly on a lower side of normal. If the testosterone is on a lower side of normal, we need to improve the testosterone first and then go on to the further line of treatment. Usually, it's for non-obstructive azoospermia, the treatment is usually IVF, and we have to surgically retrieve sperms from the testis. Surgical retrieval of sperms can either be testicular sperm aspiration or microsurgical TSA, which we will discuss later. And the third important scenario is where the FSH and LH levels are normal and even the testosterone levels are normal. In this scenario, the cause is usually obstructive azoospermia, where there is a obstruction to the outflow of the sperms, and this is a scenario again where either the obstruction can be released by doing a reconstruction of the vas deferens, or you can surgically retrieve sperms and do IVF ICSI in such patients.
Very well elaborated, sir. So these are the causes, and how do we go ahead with each and every situation that we come across. So can we have a short discussion about what are the treatment modalities that we have, or according to the situations of these patients? What are the treatment modalities that we have, and what all complications that that the patient can face if they go through this surgery?
Yeah. Uh, yes. So we talked about diagnosing different conditions, whether it is pre-testicular, testicular, or post-testicular. Once we confirm our diagnosis, then further investigations are also necessary before we go on to the next level of management. So, in the further investigations, if it is a hypogonadotrophic hypogonadism, then we need to see if there is any genetic cause for it, such as the Klinefelter syndrome, where there is a one extra X chromosome, or a Kallman syndrome. We need to analyze that. So, genetic testing or karyotyping is mandatory in such patients. For even non-obstructive azoospermia, karyotyping is mandatory because translocation of chromosomes or inversion of chromosomes can lead to problems with the sperm production. So this can also be a cause. Y chromosome malfunction can also be a cause. So we can do a Y chromosome microdeletion test where we can see which area of Y chromosome is dysfunctional. Is it AZFA, AZFB, or AZFC region? And depending upon that, our outcome will be analyzed. Third important scenario is obstructive azoospermia. Here we do the examination of the patient and see if the vas deferens is present. If there is bilateral absence of vas deferens, we do a test called as CFTR gene mutation, where the cilia production in all over the body is problematic, and therefore this can be a problem. So this in this way we completely evaluate the man by doing the other tests. Other than this, probably we need to do an ultrasound of the testis to analyze the testicular volume. In cases of non-obstructive azoospermia, to see for any other problems, and in cases of in cases of non-obstructive azoospermia, again we see for presence or absence of varicocele, which is going to cause testicular damage, and so on. So, ultrasound and a Doppler of the testis is again an important investigation which should not be missed before we go ahead. Now, about the line of management or treatment. If it is a hypo or pre-testicular cause, then the hormones are less, and therefore we need to supplement hormones in these patients. So we can give gonadotropin hormones twice or thrice a week, and along with that, this we can be given as HMG or FSH. Along with that, HCG can also be given on a bi-weekly basis, 2000 international units. uh, with this, if the testosterone levels are low, we can also supplement with other agents, oral agents as well. Along with that, the this patient counseling remains a very important factor in this patient, because the patient will expect result immediately. That is not going to happen. Once we supplement with hormones, it is going to take few months to maybe an year or 1.5 years for the sperm production to be absolutely normal. So if these patients have to continue these hormones, and when they start producing sperms, these sperms can be frozen for future use. And of course, if they reach to a normal sperm count, then they can try naturally as well. If they don't reach a normal sperm count, probably they need to freeze sperms and use them as and when required for ART techniques, that is either IUI or IVF, depending upon the count motility factors. So that is the treatment of pre-testicular causes. Regarding post-testicular causes, where there is obstruction, uh, help of urosurgeon is very very helpful, where we can do an intraoperative vasogram of the patient and analyze where the obstruction is. And after the obstruction has been identified, we can either do a vasoepididymal reconstruction or a vasovasal reconstruction of the vas deferens and release the obstruction. And this can effectively bring the sperms outside, and the patient can conceive normally. However, it has been shown that the success rate of reconstructive surgeries is slightly lower, to the tune of around 50 to 55%. So, this prior counseling for the patient is very much necessary before we go for the surgery. Third important thing, along with that, for obstructive causes, we can also do a testicular sperm aspiration, that is a small testicular biopsy. And along with that, IVF ICSI treatment can be given to the patient with a conservative, like slightly conservative surgery than the reconstructive surgery, and the success rates are quite good with PISA and ICSI procedures for obstructive azoospermia. In cases of non-obstructive azoospermia, the sperms are very very less, or in a primitive level, sometimes we only get spermatids, and they are present in very low levels in the seminiferous tubules. Therefore, a normal testicular biopsy may not give you good results. These are the patients in whom extensive counseling is necessary, that their procedure for sperm retrieval can be either testicular sperm aspiration or microsurgical technique, where a microscope is used to retrieve sperms from the seminiferous tubule. So seminiferous tubule by tubule is retrieved out of the testis, and these tubules are placed under the microscope, and then the sperm is identified. This tends to give us more number of sperms and better sperm yield than the normal testicular biopsy or TISA procedure. After getting these sperms can be frozen, or they can be used immediately if the patient's wife is undergoing IVF simultaneously. The results of fresh sperms retrieved by TISA or microtese are slightly better than the results of frozen sperms. If the wife is not prepared, these sperms can even be frozen. Now, at Oasis, we have this technique where even if we get one or two sperms, these sperms can be frozen by a technique called as sperm VD, where it is easy to retrieve the sperms later on, even if the count is less. So these are the techniques where we can offer treatment. And after doing the sperm retrieval techniques, we can use the sperms by intracytoplasmic sperm injection and prepare the embryo, mature the embryo, and then transfer the embryo. We should be telling the patient that sometimes, even at the best of the hands and at extensive time, sperm retrieval may not be possible in non-obstructive azoospermia, and the success rate will be slightly lower, and the sperm retrieval can be possible in around 50 to 60% of the patients. 40% patients we may not retrieve any sperms, and therefore consent of donor sperms has to be undertaken if the patient is undergoing IVF simultaneously. If the patient is not undergoing IVF simultaneously, then post-operative counseling of the patient becomes necessary. So these are the treatment options which are available for azoospermia. Over to you, Dr. Kanchan.
Yes, sir. So these are the various treatment modalities according to the causes that can be there for the azoospermia or zero sperm count. So, what are the complications that the patient can face if they undergo, or what they come with the anxiety that what all complications they have, or what time of rest they may have to take after they undergo the surgical retrieval procedures?
Many of the surgical procedures which are undertaken for male infertility, whether it be testicular sperm aspiration, microsurgical TSE, varicosilectomy, or any other surgery, many of these surgery are now daycare surgeries where the patient is admitted and discharged on the same day within few hours. So less chances of any complications, very less pain, and no effect on their sexual activity. This needs to be highlighted because many men are worried about their sexual life after the surgery. So there is no effect on the sexual life after their surgery. This should be highlighted.
Yes. So now coming to the last question of this session, that what is the success rate? What how is the percentage retrieval rate, and after that embryo formation, and what success rate in approx for these patients with azoospermia or zero sperm count? Are the pregnancy rate good, average, poor?
Yeah. So one thing which is needs to be understood that if the patient has any genetic problems along with azoospermia, the success rates might drop. And if we diagnose those genetic problems before doing IVF procedures for these patients, we can do what is called as a pre-implantation genetic testing for aneuploidy or PGT-M or PGT-SR for such patients if there are structural rearrangements. So this can be undertaken before we transfer the embryo. So we can improve and optimize our success rates. The success rates in general are depend on the sperm retrieval. The chances of sperm retrieval, even in cases of non-obstructive azoospermia with microsurgical TSE, they are around 50 to 55 to 60%. So at the best of the hands, we can have a good sperm retrieval. After the sperm retrieval, depending upon the sperm quality, the success rates of IVF will depend, which are somewhere between to the tune of around 40 to 50%. So we have fair success, and these patients of azoospermia need not be worried. They should take a proper medical guidance, and even in cases of azoospermia, we can have babies with their very own sperms. If everything fails, then we have the option of donor sperms, but that remains the option. The first priority is to get the sperms out of the patient. Dr. Kanchan, I think you are muted.
Yeah. So that is what every patient wants, that they want the babies from their own genes, that is their own sperms. So at Oasis, our try is always there that the patient could have their own sperms, own gametes, and with that they can have the pregnancy and good success rate. So thank you, sir, for your guidance. If uh, any addition you want to do from your side?
I think that's enough for this topic.
Yeah.
Thank you so much, Dr. Kanchan.
Yes. So, thank you all our viewers. Thank you very much. If at all you have any queries, you can put it on the chat box, or we have the helpline number flashing on your screen. There also you can ask your queries. For consultation, you can call on the helpline number that is flashing on your screen, or for physical consultation, our center is at Oasis Fertility, Vakad, Pune, or Kharadi. Thank you all for your patient listening. Uh, Thank you, sir. Thank you all very much.
Thank you.